Is promoting a multifaceted model of depression in African American women. We have a good number of people that are joining us online, and we're expecting more people to join us here in the room. But they have a lot of material that they want to cover, so let's go ahead and get started, if that's okay by you.
Yes.
You want to go ahead and introduce yourself, and we also have a co-presenter presenting online, so we're going to tag team.
Nice. Yes, so today we're going to be talking about culturally competent treatment, promoting a multifaceted model of depression in African American women. My name is Dr. Chalice Rhodes. I'm an assistant clinical professor in our counseling and family therapy department, and I'm the director of our behavioral health counseling program. My co-presenter, Dr. Bernice Kennedy, is an advanced practice nurse, and so she is joining us from South Carolina to present. Yes, so she is zooming in online with some of the other participants. I will get us started. I will present a portion of it. Dr. Kennedy will present the other portion of it. If people online have questions, you can type your questions in. Darren will let me know, and we will answer those. We have a lot of material to cover. We do have to end this session a little early, so at around 12:50, because we have an all-staff meeting. So let's get started with our objectives. So our objectives for today is that we're going to discuss the incidence and prevalence of depression in African Americans. I'm going to provide you all with an overview of African Americans and depression. We're going to analyze the historical perspective of African American women and the challenges associated with the various struggles that African American women face, forms of oppression, and negative character stereotypes. I'm going to present an overview, or Dr. Kennedy is going to present an overview of the multifaceted model of depression in African American women. So you all have a handout right in front of you, which is the actual model. Also, for those online, Darren graciously emailed that to you all in advance, so you can take a look at that and refer to it. And then we're going to explore some strategies for improving health outcomes of African American women who struggle with depression. So I'm so sorry for this small writing, but there is a lot to be covered in the DSM-5, right? So the DSM-5 is what we refer to as the Bible of mental health. DSM-5 is an manual that defines clinical disorders. Okay, so the DSM-5 states that an individual must experience 5 or more of the symptoms listed in the same 2-week period, okay? At least one of the symptoms has to either be a depressed mood or loss of interest or pleasure. So at least 5 of the symptoms I'm about to talk about in the same 2-week period, and a predominant symptom has to be either a depressed mood or loss of interest or pleasure. Here are the symptoms. A depressed mood for most of the day, nearly every day. Markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day. All right, this is clinical depression we're talking. Significant weight loss when the person is not trying to diet, or weight gain, or a decrease or increase in appetite nearly every day. A slowing down of thoughts and a reduction of physical movement, which we refer to as psychomotor retardation, right? And this is observable by others. So it's not just that the person feels this on the inside. They could be feeling this internally, but others are also able to observe this. There's fatigue or loss of energy nearly every day. There's feelings of worthlessness or excessive or inappropriate guilt nearly every day. There's diminished ability to think, to concentrate. There's indecisiveness nearly every day. The person just can't make a decision, to struggle just to get it together with clinical depression. There could be recurrent thoughts of death, recurrent suicidal ideation without a specific plan, or a suicide attempt, or a specific plan for committing suicide. Now, to receive a diagnosis of depression, remember the person has to have at least 5 of these symptoms, right? They need to present with either depressed mood or loss of interest or pleasure, and it needs to be in the same 2-week period. To receive a diagnosis of depression, these symptoms must cause clinically significant impairment in the following areas, right? Impairment in social, occupational, or other important areas of functioning. The symptoms must also not be a result of substance abuse or a medical condition. So this is why, as mental health professionals, We cannot just automatically just diagnose a person with a major clinical depressive disorder if they have 5 of these symptoms. We need to have a full medical exam to make sure there's no medical disorders that may be interacting or causing symptoms of depression. And then there are certain substances. When people are abusing substances upon intoxication or upon withdrawal, they may experience depressive symptoms, and it may just be related to the substance. Now, there's also 2 specifiers that are mapped out in the DSM-5. There's a mixed feature specifier. Now, this includes the presence of manic symptoms when a person does not meet the full criteria for a manic episode, right? So mania goes with what we call bipolar disorder, bipolar 1 or bipolar 2 disorder, but for the purposes of our discussion, we're just talking about depression. With anxious distress, the presence of anxiety in patients may affect their prognosis, their treatment outcomes, and how the patient actually responds to them. Clinicians need to assess whether or not the individual experiencing depression also has anxious distress. All right, so that gives you the clinical formulation of what we refer to as clinical depression, right? Because we all know that we all go through tough times. We all have sad times. We all experience blues. There's grief and loss that can come into play. But for the purposes of this discussion, we're talking about clinical depression. So let me give you guys an overview of the prevalence of depression. So this is data from the National Health and Nutrition Examination Survey from 2018. During 2013 to 2016, 8.1% of American adults aged 20 and over had depression in a given 2-week period. Women were twice as likely as men to present with depression. The prevalence of depression actually decreased as family income levels increased. About 80% of adults with depression reported at least some difficulty with work, home, and or social activities. From 2007 to 2008, in comparison to 2015 to 2016, depression levels really didn't change. Depression was lower among non-Hispanic Asian adults compared with Hispanic, non-Hispanic Black, or non-Hispanic white adults. And as you all can see from this diagram shows us exactly this. This is from 2013 to 2016, and the prevalence rates of depression. Clinical depression rates are lower among Asian men and women, right? They're highest among African Americans. So the darker blue represents the Hispanic population. The next color, purple, is non-Hispanic white. The lavender color, which we were talking about today, non-Hispanic Black. And then the green represents Asian. All right. Let me give you guys an overview of what we're going to talk about today. So, in general, there is a lack of both diagnostic and treatment studies that historically plague the fact that there's not a lot of research on African Americans. There's research out there, but much more research is needed. African American women experience racism, sexism, and poverty. Depressed African American women may perceive themselves as being devalued by society, and they may find that they have fewer supports when they have stressful life events. Depressive symptoms may develop into actual clinical depression, which is what I talked about earlier, and a further decrease in the quality of life for African American women. Now, this one is really important because there's this assumption that all women share the same experience. That's not true. There's individual differences even within certain ethnicities and certain races. So even though I'm saying African American women, it's really some African American women may experience this. Not all African American will experience this, and it's going to present itself differently. So the assumption that all women share similar experiences, it doesn't actually allow for differences to emerge regarding the diagnostic process, measuring tools, successful treatment strategies for various cultures, not even just African Americans. African American women are at risk compared to their white counterparts for experiencing stress and negative outcomes such as in areas of health, education, and in their well-being. African Americans drop out of services at a significantly higher rate than whites, and they use fewer treatment sessions for mental health services. African American women have a higher prevalence rate of depression, anxiety, and phobia than African American men. And African American women experience multiple problems in their lives because they contend with gender, race, and class issues. Discrimination is encountered among African American women, both within their communities and outside of their communities. African American women may experience racism from not only women, but men as well. And the influence of race and gender broadly impacts how Black women can develop in a professional environment. Black women tend to suffer poorer mental and physical health outcomes than other ethnic groups, regardless of their socioeconomic status. So many times, a lot of research is done in low socioeconomic status populations, but this is true even across populations, socioeconomic status populations. African Americans also drop out of services at a significantly higher rate than white Americans, and they use fewer sessions. African Americans account for approximately 25% of the mental health needs in this country, yet they only make up 11 to 12% of the US population. Also, there's only 2% of psychiatrists represent the African American population. African Americans are also underrepresented in some private practice outpatient populations, but then they're overrepresented in some inpatient populations. And they're more likely than white Americans to use the emergency room for mental health treatment versus seeking ongoing treatment. African Americans tend to enter treatment at a later stage and a more advanced stage compared to white Americans. They tend to access at a low rate community mental health services, and they are misdiagnosed with severe mental illnesses compared to white Americans. An example is schizophrenia. African Americans tend to be overdiagnosed with schizophrenia. Providers will go to the more severe disorder before considering, some providers, before considering bipolar disorder with psychotic features or schizoaffective disorder. African Americans are often misdiagnosed, or they may have withdrawn from treatment because their ethnic, their culture, or their gender needs are not being met. And African Americans do not tend to participate in research studies because they are uncertain as to how the research data will be used, how it will be disseminated, and they're afraid that the actual data will be misinterpreted. Okay, so now we're going to have Dr. Kennedy go into the historical perspective. You ready, Dr. Kennedy?
Yes, I was hoping to see the slide, but I can't see it from that view. Okay.
Can't see the slide. Okay.
Our video, our pictures is right in front of it. I'll try my best. At the beginning of the century, African Americans themselves achieved and reaching a new milestone. You know, education and hard work did not always paid off. Despite the news, African Americans still find themselves lagging behind white and other ethnic groups. And next slide.
Okay.
African American experienced role conflict between professional development, a lot of family responsibility, guilt feeling for taking away from their mother, contribute to depression, and a struggle to balance the multiple roles. Okay. African American women historically experienced numerous challenges associated with various struggles, form of oppression, negative characteristic of stereotype views of the African American, especially females. These stereotypes impact on the African American social well-being. The strong Black women archetype dating back to slavery describe the coping mechanism with oppression in terms of the female role. Scholars have traced this back from generation to generation. Despite the adoption of women, continue to experience challenges, hardship, financial hardship, primary caregiving, racism and sexism has been a part of the African American woman in terms of historical perspective. I think she said that Dr. Rhodes said you all have a copy of the model.
Yes.
This model that we developed conceptualized depression and culturally competent in African American women. The model is useful looking at a holistic approach in terms of biopsychosocial spiritual factors contribute to depression for culturally competent treatment of African American women. And this model is so important to look at the African American woman in terms of treatment, in terms of a holistic perspective. Okay. And when you look at it, you see the causal conditions, biopsychosocial spiritual factors contributing to depression, and then strategies for development, for improvement. And we're going to talk about all of these areas. Next slide. Health professionals working with African American women need to be aware of biopsychosocial spiritual factors contribute to depression. And I often talk with my nurse practitioners that out in the field, and the ones I'm teaching now at the university, about obsessing for depression, and for the African American women that they have to look at it from a holistic perspective, because assessing the African American woman may be different from other ethnic groups. Next slide. In the model, biopsychosocial spiritual factors affecting depression in the African American woman are as follows. We're going to talk about the environmental factors, socioeconomic factors, health factors, cultural factors, and then we're going to talk about the psychosocial, looking at stress factors, coping, and social support. Environmental condition. And often the African American may be living in poverty, in drug infested areas, high incidence of incarceration, homeless, a large number of foster care throughout, which will have impact on health outcomes. Racism in the U.S. resulted in negative outcomes for African American females. Stressful living conditions such as poverty, discrimination, racism, abuse, and rejection from American society may contribute to their thoughts of suicide. Okay. Okay, did we miss? You're back to the same one. Socioeconomic factor, African American women are more likely than Caucasian women to share a higher level of socioeconomic risk for depression. Okay, go to the next slide. Psychosocial influence may influence the outcome of African American women, and these factors such as stress, coping, and social support is very important, may have a positive and negative outcome based on how she deals with depression and factors in the environment. Biopsychosocial spiritual factors. She's on the low spectrum of the political and economic continuum. African American women continue to survive financial strains and difficult in terms of the workplace, and also family dealing with family and emerging in terms of mainstream society. Socioeconomic factors continue. Regardless of her socioeconomic status, she still experienced poor health outcomes because of certain factors such as stress within the environment that she encounters. Also, she struggles too of maintaining that with the image of the strong Black woman syndrome.
Oh, yeah, they're talking about the image of the strong Black woman.
Biopsychosocial spiritual factors, health factors. African American women have numerous medical problems and a high incidence of depression. And often these medical problems may coexist with the depression, which is always good when you're assessing African American women with certain conditions such as cardiovascular disorder, stroke, and diabetes. I always encourage that you also do a depression screening. Culture factors. Culture factors play an important role in terms of depression. There's a stigma in the African American culture in terms of mental health, and it still exists today. Even in practice, I still have professional African American women that when they come in, they do not want to take the medicine because of they don't want to take medication, they don't want to take traditional medicine, and they could be clinically depressed, but they still stand strong of not taking that medication. Next slide. Cultural factors. African American woman is presented to society as strong and resilient, which date back to slavery. Often she feels like she can take care of it herself. God would take care of it. I'm not going to claim it. I'm not going to give in to these stresses. And then she can be actually suffering. Next slide. More culture factors. Sometimes African American women feel they need to pray and keep everything within the Black community. When they do access care, they may not be open and honest because they feel like they need to take care of it. When they do come access care, they come looking very good because we've always been taught that we always look great when we come to the doctor. And she'll wear her best clothes and her best attires, and she may not be open to share of what's really going on with her. Religion and spirituality help many African American women draw strength and overcome adversity such as poverty, illness, rejection, and prejudice. Okay. African American women who prescribe to the strong Black women archetype internalize stress in an effort to maintain self-reliance and not seek social support from others. Often don't seek assistance from others because of the lack of social support due to the conscious pressure to remain strong. Lack of social support contribute to extreme strong, which impact physical and psychological well-being. African American women who subscribe to the strong Black woman syndrome archetype tend to take care of others while neglecting their own self and their own health care. They're going to take care of their family. This is evidenced by a report of high sadness, hopelessness, trustlessness level. African American women tend not to prioritize self-care, social support, and mental health treatment due to perception of weakness. In some cultures, it's seen as a weakness. Going back to the psychosocial factors, stress factors, social support, these factors are mediating variables that may have a positive or negative outcome, and depending on how the African American woman, how she copes with stress situation. Okay. Okay, psychosocial factors continue. She may have such factors with high level of somatic and psychiatric illness, and stress and depression may negatively correlate with self-esteem and happiness. Okay, next. Stress factors, the strong Black women archetype increases African American women vulnerability to depression associated with high level of stress level. Typically don't seek mental health treatment, unfavorable attitude towards seeking mental health treatment. And coping factors. Coping is defined, and I can't see past this, have something in my little vision. I wish I could move this.
I'll define it for you.
Well, try to click the icon where the camera is and see if you can move it, or see if there's a option.
Okay, I'll define that for you while
Yeah,
you.
define cope. Yeah, do that.
Okay.
Because our picture is in my way in terms of the screen.
Okay, you just have to drag it to another portion of the.
Okay.
All right, so coping is defined as those abilities that actually enable an individual to buffer the negative effects of stress, right? That's how we cope. Or our psychosocial vulnerability. So general coping responses refer to strategies that are usually used to deal with stressful life events. Can you see that, Dr. Kennedy?
Yes, I still need to move this. I wish I could move this over some, but I can't. Okay. Maybe I won't see you all. Coping, today, African American women continue to use the strong Black woman archetype characteristics as a means of coping with race, gender, and discrimination. The role of strength is learned and internalized as an expectable form of cultural coping passed down from generation to generation. And go ahead on. African American women rely on cultural coping in response to stress, such as reliance on the extended family and community, religious belief, and spirituality. The research reported that African American women who internalize the strong Black women archetype engage in high effort coping, avoidance coping, postponement of self-care, and other maladaptive health behaviors and experience and premature health deterioration. African American women are likely to seek professional help by mental health, abuse, and physical illness income, are less likely to seek in comparison to other ethnic groups. Psychosocial factors continue. Social support factors. Social support is the amount of psychological assistance a person perceives is available from people such as family, friends, colleagues, and spiritual advisors. African American women who subscribe to the strong Black women archetype usually believe being dependent on others' support places her at risk for being hurt or manipulated. This self-protective strategy prevents them from mistreatment, disrespect, and pain. Fear of asking for and accepting help promote the notion that their survival of success have been left to them. Strategies for improvement. Move it again. I apologize because my view is not great. Yeah. Okay. Developing more, there's a need to develop more reliable and valid scales for measuring depression. Assessing accurately for depression of African American women, using culture sensitive tools for gathering data and obtaining histories and physicals. All these are important. Providing culturally sensitive treatment, then educating health providers on culturally competent treatment and care. Next slide. Assessing depression in African American women. Health providers working with African American women need to frequently assess for depression. And what I'm seeing now is that they do have screening tools, and it's very they're implementing them in primary care and also in hospitals. That is important to assess special certain health problems, cardiovascular, diabetes, cancer, in terms of screening for depression. So the holistic approaches begin to permeate the healthcare system. Cultural assessment tools useful for gathering data, often difficult to treat mental health challenges in African American women. Health providers often less likely to detect diagnosable mental disorders in African American women. Strategies for improvement, providing culture sensitive treatment. African American are less likely to seek treatment due to misconception about depression, stigma, and limited access to culturally relevant care. Ethnic minority barriers, stigma, misperception of mental health disorders as a stigma of weakness, of mental instability, and limited mental health insurance coverage. Providing culturally sensitive treatment continued. Often African American women seek help from family, friends, neighbors, and religious and spiritual leaders. Religion and spirituality cannot be ignored and must be incorporated into treatment. Example, prayer and meditation.
Thank you, Dr. Kennedy. All right, so now we're going to talk about some psychotherapy strategies in terms of how we can improve depression in African American women. So with African American women, we have to address these roles, these competing roles and conflicts that African American women experience, especially as African American women are achieving more and more year after year. There is this stress and conflict that they can experience within the workplace. There's also a lack of opportunities that are available. There's a lack of skilled and managerial jobs, and there may be low-paying wages. Low-paying wages, which kind of gives, there's like this ceiling for African American women to rise. Like once they hit that ceiling, if they're in a certain job, that's all they can make, and that could contribute to depressive symptoms. Now with psychotherapy, we want to make sure that we are addressing interpersonal conflicts, right? And we want to help women to develop their interpersonal skills. We can utilize cognitive behavioral therapy to correct any negative thinking, any cognitive distortions that they may be experiencing, and any associated behavior that results from those cognitive distortions and the emotions that also come along with that. Also, for African American women who are in relationships, couples therapy to reduce marital conflict or conflict with partners is also useful. Now, interpersonal and social rhythm therapy, has anybody happen to have heard of this therapy? Yeah, a lot of people, and I love to talk about it because it is such an excellent therapy that is gaining a nice evidence base. And interpersonal and social rhythm therapy, it helps people to manage their moods by analyzing their circadian rhythms, so their sleep patterns and their social rhythms, to actually help them manage stressful life events. So how does their sleep impact how they interact in relationships with others? How can that help them to manage the moods that come along with a depressive disorder? Also, interpersonal and social rhythm therapy may be effective in helping African American women to manage their depressive symptoms and to actually prevent future depressive episodes. Cultural difference play an integral role in the communication process. Now, here are some differences between African Americans and whites that can emerge, some, all right? African Americans and whites tend to assign different means of communication to verbal and nonverbal communication modes. Differences may actually promote miscommunication in interactions. Whites tend to disclose more personal information than African Americans in their initial contact. African Americans are less likely to use self-disclosure to compromise in times of conflict compared to European Americans. Also, some African Americans have a distrust of European American therapists, right? So this is a term referred to as a healthy cultural paranoia due to dating back from slavery and throughout American history, the racism, the discrimination that has been perpetrated against African Americans kind of can cause this healthy cultural paranoia. Like if professionals, mental health professionals aren't aware of healthy cultural paranoia, they may misdiagnose African Americans as being paranoid. When really, if you consider it in a context, the holistic perspective of their situation, is this really diagnosable DSM-5 paranoia? Or what is the context of the information? So we have to make sure we're considering all of that. Literature also suggests that some African American clients prefer African American therapists, but let me tell you, the research base does still say it doesn't matter what your race is, what your culture is. For most, in therapy, if you can build a relationship and connection with your client, that will make all of the difference. And it does not depend. It does not matter what intervention you're using, what particular philosophy you're coming from. The fact that you can actually build a connection with someone and the client can feel that they care, that somebody cares for them, and that this is someone that they can trust. But there is a certain sector of African Americans, they want to see a therapist that looks like them. They want to have a psychiatrist that looks like them. Representation is important. Language may differ between African Americans and their therapists, so this may cause some type of tension or conflict. African Americans tend not to readily communicate their feelings or intentions in an open exchange. And an African American family may actually have its own methods of communicating with its members. So it really is up to the therapist to learn the person's story. As therapists, we are taught that no matter what your race is, who you're sitting across from, we learn our clients' stories and we empathize with them. We try to understand where they're coming from. We try to actually walk along with them in their shoes. Psychoeducation is definitely important. We have to educate African American women on what clinical depression actually is. All of those symptoms that I discussed at the very beginning, right? They may have one symptom, they may have two symptoms, but they may actually have at least 5 of those symptoms and have significant impairment in those areas that we talked about. We may be able to rule out any kind of medical condition or substance abuse, which would point to clinical depression. So we do need to educate African American women. Also, African American women have to put forth the effort, right, to want to be successful in overcoming any fears they have about reaching out, getting past this stigma that is prevalent in our community, right? It's fearful. You don't know what to expect in the African American community. We're taught to go to the pastor of the church or seek Christian counseling, if that's, so we have to be able to overcome, African American women have to be able to overcome any fears and stigma they have related to mental health treatment. African American women must recognize that the expression of actual depressive symptoms is individual. So you have an African American woman that's comparing herself to a friend that she has who has suicidal ideation. She may say, oh, I'm not depressed because I don't have suicidal ideations. No, my friend, she's depressed. But that's only one. Suicidal ideations is only one symptom of depression. And this is the thing with depression, it ranges on a continuum. So there's mild, moderate, and severe depression. So her and her friend, for example, they both may have depression, but maybe one friend has a mild form of depression and the other friend has a more severe form. So these are all the things that we have to kind of provide education around. Okay, Dr. Kennedy, do you want to get into pharmacological treatments and finish us up?
Okay. African-American women are less likely to receive appropriate treatment for depression and anxiety based on guidelines in terms of clinical trials. African-American are less likely than whites to receive antidepressants when they're first diagnosed. And that's actually in terms of misdiagnosis in many cases. African-American are less likely to receive newer the SSRI medication than whites, and also medication with less side effects. Also, the metabolism, it has been proven that they have slower metabolism as compared to whites, and which creates more side effects. And because of those side effects, they're less likely to be compliant to their medication. Next slide. As Dr. Rhodes had talked about in terms of the church, African American vary in their level of preparation in dealing with mental health. Need to refer church members to mental health, extremely important in smaller congregation. And so often here in the South, smaller congregation often want to do everything. They want to do counseling, and then sometimes they're not prepared in terms of pastoral counseling, and they're not prepared to handle the complexity of the person's condition. Whereas some of the larger congregation, they have licensed counselors and psychologists there to assist and provide counseling. But we do have that challenges here in the South in terms of smaller congregation. Spirituality needs to be considered in the treatment of African American women, and African American women often seek counseling from the clergy, and that's still very much, it's still common here in the South, not just South Carolina, but in the South. Okay. Community support. We have church groups, schools, department, community centers, sororities. These are very important. And it was good for me to look at Owens. I think the Open Network have a forum that it was able to speak out with, in terms of African American women. I think that's continuous. They're beginning to open up more in terms of not only depression, but other mental health disorders. So they have a forum where they can go and they can talk about these issues. A need to provide more support and resources for African American women. That's very important. That need to be in various organizations. Health promotion and disease prevention also need to be probably in schools and PTO meetings and so forth. And African American women seek their healing through other women with similar experiences. And I think this is, sometimes they do that. They form their own social support groups. Okay, next. Culture sensitive education for health providers. Just like Dr. Rhodes said that we only have 2% of our African American psychiatrists, and so it's not always feasible that they will be able to go to an African American professional. So it is good to have that background in terms of being culturally sensitive for the healthcare professionals and so forth. Health professionals need to take the lead in educating the public on health issues of African American population in terms of disparities, treatment, consultation, etc. Need for more conferences, workshops on culturally competent care of African American. Next slide. And just, I think this Sunday, one of the pastors, I thought was very, very great in terms of discussing depression, and that was one of the issues that they was going to discuss. It was one of the larger congregations discussing the depression, and you can see a lot more in the larger congregation of the churches here that they do more faith-based education, and have the health professionals who in their church to assist and educate their congregation. Culture sensitive education of health providers. Holistic treatment has been beneficial and effective. This approach is encouraged by family, friends, neighbors, religious leaders in the African American community. And I talked about the education of health professionals. Health professionals need to be educated on identifying common symptoms of depression in African American women. And I think that need to be a thread and strain in terms of the curriculum within, whether you be medical, nursing, psychologists, and so forth. I think it needs to be taught within the universities also. Health professionals need to know the language of African American, and cultural barriers including in the presentation of symptoms that may influence language and behavior mannerism. Even here in South Carolina, there's different language in terms of how people communicate, whether they're in the rural areas or the metro areas. You need to know, be culture sensitive in terms of their language and how they may communicate their healthcare need. Okay. Okay, we're at the end. The multifaceted model of African American women and depression is a useful model with a holistic perspective in developing culturally sensitive treatment and research on African American women. This model includes biopsychosocial spiritual component, including many factors contributing to the development of depression in African American women. The disparities in mental health treatment of African American women are based on these factors: environment, socioeconomic status, health factors, cultural factors, and psychosocial factors influencing positive and negative outcome. Is basically how they cope with factors such as stress, coping, and social support. And at the very bottom of that model, if you look in terms of intervening factors, conditions are based on strategies for improvement. The faith-based community need to be included in terms of their treatment and demonstrate cultural specific treatment. The strong Black women archetype needs to be considered when planning and implementing mental health strategies for African American women. A holistic approach discussed in this model can improve the health outcomes of depression in African American women.
Thank you, Dr. Kennedy. And I just wanted to let everyone know, coming in 2020, we're going to have a 3-hour cultural competence training on this topic. We're going to incorporate some fun exercises to really apply this model to actual situations. So please look out for that announcement. Do we have time for questions?
Yeah, we have a few minutes.
Okay. Does anybody have any questions they would like to ask Dr. Kennedy tonight? We do have a few minutes. Hi, Sherry.
Hi. I can't see who's in the room and how people are making themselves known, but I would love to ask a question.
Sure.
So first of all, thanks to both Dr. Kennedy and Rhodes for the presentation, and it's a very important topic. And as a mental health professional and educator of mental health professionals, it's really, really bringing forward something we need to bring forward more in our trainings. And I've done a lot of study of coping, so these questions are a little bit nerdy. So one is my curiosity and not having very much knowledge yet about the strong Black woman archetype, and wondering, when you're talking about being aware of the archetype being sort of active, if there's any way that sort of living in or embodying the archetype might actually, sort of also come with it a sense of self-efficacy, and if the sense of efficacy could contribute to, good results in treatment for depression. I know that depression comes with its sense of hopelessness, but I wondered if there's any sort of protective factor in the archetype when it comes to self-efficacy.
Yes, and we talk about that more in depth in the actual paper. So this resource at the very end, where you can actually download the article. If you don't have it, you can go right to the brkhealthcare.com website and download the article. But yes, the strong Black woman archetype, right? So it can serve as a positive. It can have a positive effect. It can have a negative effect. It can have a combination of both. And I also want to say, for some African American women, they're not going to actually identify with the strong Black woman archetype, because for them, it's just who they are. It's just who we are. It's no archetype. It's just what's in our genes. It's just what we've seen from our ancestors and from our grandparents and our mothers. But yes, it can serve as both a protective factor and also can have positive and negative consequences. You know, if we rely on that only and we don't reach out for support or we don't reach out for help, and you're talking about that in the context of depression, it's an isolating disorder anyway. You know, it can further the depression. So I hope I answered your question.
Thank you. Yes, I'm really excited to read the article.
Oh, good. Dr. Kennedy, did you have anything you wanted to add?
And I know they're in the process. I've seen a lot of new research on that area with African American and strong Black woman architect in terms of health outcomes. And like Dr. Rhodes said, it can be, in some cases, it can be in terms of positive, negative outcomes in terms of how we internalize the stress. It may have impact on some of our health outcomes. So it just depends. And new research is beginning to emerge using that particular model.
Cool. So is there time for a second question?
Another question here in the room.
We have one in the room.
Okay.
Sorry, Sherry. It's
No problem.
The question refers back to the social rhythm therapy,
Yes.
and I'm assuming that it means just more than getting more sleep.
Oh,
So maybe if
definitely.
you could just take a minute to sort of maybe articulate a little bit more.
Okay, so interpersonal social rhythm therapy, I would recommend anyone to Google that because there is this online training that you can take to get like certified in it. You receive a certificate and it takes you through it. But what you do is you actually, when you're in the room with your clients, you're actually examining the client's lifestyle and their everyday patterns. So we talk about self-care and how having a self-care plan is important. Well, what does their self-care plan look like? How are they eating? How are they sleeping? What are their sleeping habits? Okay, let's now get into the interpersonal part, the relationships. So what do their relationships look like? What are the positive parts of the relationship? Are there any negative aspects of the relationship? Do they notice that when they have a lack of sleep, that they tend to be more moody, right, than when they're not? Do they notice that when they have a lack of sleep and when they interact with this certain person in their life, that really impacts their mood? And then they may be in this depressive mood or maybe even a manic phase for 1 or 2 weeks. So it's really, I've used it in practice with clients, and it really has been very much effective with my clients using that particular therapy for clients who have struggled with major depressive disorder and for bipolar disorder, especially for bipolar disorder. I saw it in my practice with clients. So I would recommend anybody, you can Google it. There's like a complete training that you can do on it with materials and everything that you can use with your clients.
Thank you.
Welcome.
I don't have a question, but I just want to see if this will be part of the training next year. I'm really excited about it. So I love the spiritual added to the biopsychosocial, very important. Also the role of the church.
Yeah.
But I'm curious about the intersection of the church and therapy. When the church denounces therapy, it is undoing everything that the client is working towards, and have gone as far for me personally, inviting the pastor to come into a session and like flat out refusing.
Wow.
And then doing an exorcism on the client, and that person had severe trauma.
Wow.
So it was really sticky, and
Yes.
obviously a client case, I don't want to go down that rabbit hole, but I'm wondering if that's something that'll be looked at or talked about more in the training, or can I like put a plug for that?
Yeah, that's a nice little plug. I'm like, the wheels are turning. I'm like, oh, we may have to. Yeah, I think that's something that we can definitely incorporate.
Yes.
You know, like in a role playing and incorporating that aspect, because I am happy to see that. I'm happy to see more pastors even talking about mental health, and pastors outwardly saying, I can treat this aspect, I can treat the spiritual aspect, but I need to now refer you to a professional. And like Dr. Kennedy said, with some of the larger churches having actual professionals on site, but then you have the smaller churches too, and everybody's trying to do everything, and the training isn't there that's needed for the severe DSM-5 disorders that we're talking about.
Yeah.
Yeah,
Oh,
thank
good.
you
Oh,
for
good.
that.
Put a plug in.
Yeah, that was good.
I'll
Thank
talk
you.
to you more about it.
Okay,
Free,
yeah.
so I can
Wonderful.
learn.
Okay, thank you.
I just had a comment. I thought it was a great presentation, and I like the fact that I think it was Dr. Kennedy that looped back around when she talked about African Americans not wanting to take medicine. But when
Yes.
she came back around and said because the study of the side effects on African Americans compared to other people. Like, that's the reason why they don't take it.
Yes.
And also, if y'all don't offer this already, I think it should definitely be offered to people like in the community,
Yes.
like in West Philly and North Philly, we have the different what's that, dorm site?
Yeah, the dorm
site
site.
locations.
Yes.
Yeah, and a lot of people, if they don't have access to the internet, send flyers or something out.
Yes.
This is definitely helpful.
Thank you. Thank you.
Well, I think we're just about at our time. Thank you, Dr. Kennedy, for joining us
Yes.
remotely.
Thank you, Dr. Kennedy.
Thank you so much.
Thank you. This was wonderful. Stay tuned for more Tuesday topics. This is the last Tuesday topic of the quarter.
Of the year.
Of the year, yeah.
Here.
Of the year. So we'll see you again in 2020.
All right. Thank you. Thank you all.